The anterior pituitary glands contain 5 hormone-secreting cell types. Gonadotropes secretes gonadotropins. Somatotropes secretes growth hormone. Thyrotropes secretes TSH. Adrenocorticotropes secretes ACTH, while lactotropes secretes prolactin. These hormones are under the control of hypothalamic hormones. GnRH stimulates gonadotropins. Growth hormone-releasing hormone stimulates growth hormone. Thyrotropin-releasing hormone stimulates TSH. Corticotropin-releasing hormone stimulates ACTH. The only exception is dopamine. It inhibits prolactin release. So prolactin may increase due to tumor of the lactotropes increasing prolactin secretion, or a problem that affects dopamine production, such as hypothalamic disease, or affect dopamine transfer through the pituitary stalk, either tumor or trauma, or affect dopamine receptors, and some drugs act like this. Now let's discuss these etiologies in some details. Causes of hyperprolactinemia may be physiologic or pathologic. Physiologic causes include pregnancy, nipple stimulation, and stress. During pregnancy, serum prolactin level increase. It is probably due to the increasing serum estradiol concentration. By 6 weeks after delivery, estradiol secretion decrease and serum prolactin usually return to normal level. Nipple stimulation during breastfeeding increase serum prolactin, likely through a neural pathway. Stress, whether physical or psychological, can lead to an increase in serum prolactin concentration. However, the magnitude of the prolactin increase in response to stress is relatively small, and the values rarely exceed 40 nanogram per ml. On the other side, pathological causes may be hypothalamic pituitary cause, drug-induced, or other causes. An important pituitary cause is prolactinoma. It is a lactotrope adenoma and accounts for 30 to 40% of all clinically recognized pituitary adenomas. Most of prolactinomas consists of lactotrope cells, but about 10% include other cell types, such as growth hormone-producing cells. Prolactinoma are classified into 2 categories according to size. Microadenoma, when the size is less than 10 mm, and macroadenoma, if the size is more than 10 mm. Prolactin secretion by prolactinoma is characterized by efficiency and proportionality. Efficiency means that even a small microadenoma can secrete sufficient prolactin to cause hyperprolactinemia, while proportionality means that serum prolactin correlates with the size of prolactinoma. For example, adenoma less than 1 cm are typically associated with serum prolactin values less than 200 nanogram per ml, while adenomas between 1 and 2 cm are associated with values between 200 and 1000 nanogram per ml. And lastly, adenoma more than 2 cm is associated with values above 1000 nanogram per ml. Other hypothalamic pituitary causes include pituitary adenoma other than prolactinoma, which compress the pituitary stalk, preventing a transfer of dopamine from the hypothalamus to the anterior pituitary. Hypothalamic tumors is another etiology, most commonly craniopharyngioma. It may damage the hypothalamus or compress the pituitary stalk. Infiltrative disease of the hypothalamus, such as sarcoidosis, is another cause, and dissection of the pituitary stalk due to head trauma or surgery is also another cause. Many drugs can result in hyperprolactinemia. This includes antipsychotic drugs such as risperidone, phenothiazines, and haloperidol. They are dopamine 2 receptor antagonists associated with increased serum prolactin levels. SSRIs such as paroxetine and fluoxetine have a minimal impact on serum prolactin levels. Metoclopramide, domperidone, and gastric motility drugs are dopamine D2 receptor antagonists. Methyldopa is antihypertensive medication. It inhibits dopamine synthesis. Verapamil is a calcium channel blocker. However, it has unclear mechanism for increasing serum prolactin. Other causes include idiopathic hyperprolactinemia, if no cause is identified, and also MRI identified no microadenoma. Hypothyroidism results in increased TRH release, which stimulates lactotropes to secrete prolactin. Chest wall injuries, such as severe burn, results in increased serum prolactin secretion, likely due to a neural mechanism. Estrogen administration is another etiology, and also chronic renal failure, mainly due to increased prolactin production, but also due to decrease in metabolic clearance rates. Regarding diagnosis, symptoms include infertility, oligomenorrhea, or amenorrhea. These symptoms are due to hypogonadism, as hyperprolactinemia inhibits LH and FSH secretion via inhibition of GnRH release. Galactorrhea is a less common presentation. During history, ask about possible causes, such as pregnancy, drugs, such as risperidone, metoclopramide, antihypertensive medications. Ask about symptoms suggestive of adenoma, such as headache or visual symptoms. Ask about hypothyroidism, and ask about history of renal disease. During examination, test for chiasmal syndrome, for example bitemporal field loss. Examine the thyroid glands and look for chest wall injury. Investigations include measurement of serum prolactin. Normally, serum prolactin range from 5 to 20 nanogram per ml. Diagnosis is based on elevated serum prolactin, more than 20 nanogram per ml. Repeat testing for slightly elevated levels, I mean between 21 and 40 nanogram per ml, before making a diagnosis. Other lab investigations include assessment of thyroid function to detect hypothyroidism and assessment of renal function to detect renal problems. One clinical scenario to consider is the presence of macroadenoma. However, serum prolactin level is mildly elevated, I mean in the range between 20 and 200 nanogram per ml. Explanations include a poorly differentiated adenoma, or adenoma which is predominantly cystic, with minimal prolactin producing cells. And the third explanation is Hock effect. Hock effect results in a falsely low serum prolactin level, in the range between 20 and 200 nanogram per ml, despite the presence of a macroadenoma. The excessive amount of serum prolactin saturates both capture and detection antibodies. To solve this problem, repeat the test with 1 to 100 dilution of serum to avoid this artifact. To understand the Hock effect, let's review how the test works. The test detects serum prolactin by capturing serum prolactin between a capture and detection antibodies to be able to measure its level. However, when there is so much serum prolactin concentration, it saturates both the capture and the detection antibodies, preventing them from detecting serum prolactin level. This is known as Hock effect. MRI of the head is recommended for all patients with hyperprolactinemia to evaluate the hypothalamus and pituitary for the presence of a mass lesion, unless the etiology is known, such as the presence of drug-induced hyperprolactinemia. Regarding treatment of hyperprolactinemia, it is indicated when it causes hypogonadism by suppressing gonadotropin secretion, or when it causes a bothersome galactorrhea. Management options of pituitary adenoma includes dopamine agonist drugs, surgery, or radiotherapy. Dopamine agonist is the first-line treatment for hyperprolactinemia associated with lactotrope adenoma. And cabergoline is the recommended first choice due to its efficacy and the favorable side effects profile. The main side effects are nausea, postural hypotension, mental fogginess, and less common side effects include nasal stuffiness, depression, Raynaud's phenomena, and constipation. To avoid such side effects, start with a small dose of dopamine agonist and take medication with food or at bedtime. The dose of bromocriptine is typically started with 1.25 mg at bedtime for 1 week, followed by 125 mg twice daily for 1 to 2 months. The dose can be adjusted up to 2.5 mg or 5 mg twice daily if required. On the other side, cabergoline is a long-acting drug. It is started at 0.25 mg twice a week and can be increased up to 0.5 or 1 mg twice a week if required. Regarding efficacy of dopamine agonists, they are effective in over 90% of cases. Serum prolactin will decrease within the first 2 to 3 weeks of therapy. Adenoma size will decrease within 6 weeks to 6 months after starting therapy. And the normalization of pituitary function follow decrease in serum prolactin and reduction in the size of adenoma. This pituitary function includes a return of menses and fertility in women, and increase in testosterone production and sperm count in men. To monitor treatment, evaluate the patient after 1 month to measure serum prolactin and ask about side effects. If serum prolactin return to normal, continue the same dose of medication. If serum prolactin improved but not normal until now, you can increase the dose up to 1.5 mg of cabergoline 2 or 3 times a week, or up to 5 mg of bromocriptine twice a day. If the medication is intolerant or there is inadequate response, change the dopamine agonist drug to another drug or consider surgery. Regarding long-term follow-up, continue treatment for at least 1 year. After 1 year, if serum prolactin is normal, we can decrease the dose of dopamine agonist. After 2 years, if serum prolactin is normal and no adenoma is detected, discontinue medication and measure serum prolactin after 3 months and yearly thereafter. If serum prolactin increases at any time during follow-up and become more than 100 nanogram per ml, restart medication and perform MRI of the brain. Regarding neurosurgical intervention, it is indicated if there is unresponsive pituitary tumor or symptoms worsen. Transsphenoidal route is the preferred surgical approach. Rare complications associated with neurosurgical intervention includes intraoperative hemorrhage, cerebrospinal fluid leakage, rhinorrhea, diabetes insipidus, damage to the pituitary cell type, or meningitis. Radiotherapy is another option if surgical resection is not feasible, or the tumor persists or exhibits aggressive behavior. However, the risk of hypopituitarism makes this option a poor choice. Regarding management of hyperprolactinemia due to etiology other than prolactinoma, if the etiology is pituitary adenoma other than prolactinoma, surgical removal is advised. However, dopamine agonist therapy can be used if surgery is not possible. If the etiology is drug-induced, stop medication or switch to another drug without dopamine antagonist effect is an option. If the etiology is hypothyroidism, thyroxine is the treatment. If macroprolactinemia is the etiology, then pre-treating serum with polyethylene glycol before prolactin measurements can solve this problem. So what is macroprolactinemia? As you know, the majority of prolactin in the blood is monomeric. However, dimeric and polymeric form may also coexist. This results in a big prolactin known as macroprolactin. Macroprolactin is physiologically inactive, so it results in increased serum prolactin without typical symptoms of hyperprolactinemia. And lastly, regarding management of adenoma and pregnancy. Before pregnancy, discuss the risk of adenoma growth. In microadenoma, 2.7% of cases will grow during pregnancy. On the other side, in macroadenoma, 22% of cases will grow during pregnancy. And the aim of therapy differ according to the size. In microadenoma, the aim of treatment is to restore ovulation, while in macroadenoma, the aim is to shrink adenoma before pregnancy by using dopamine agonist until adenoma no longer above the cella, or the use of a transsphenoidal surgery if the adenoma elevates the optic chiasm, or adenoma is unresponsive to therapy even without optic chiasm elevation. During pregnancy, stop dopamine agonist once pregnancy is confirmed, and monitor for adenoma growth. This should be performed frequently, at least every trimester. Ask about symptoms of headache or visual disturbance every time the patient visits the clinic. Regarding measurement of serum prolactin, physiologically serum prolactin increases during pregnancy up to 400 nanogram per ml. For this reason, the Endocrine Society recommend against measuring serum prolactin during pregnancy due to the difficulty in distinguishing between the normal pregnancy-associated hyperprolactinemia or a rise in serum prolactin due to adenoma growth. However, up-to-date textbook recommend the measurements of serum prolactin every 3 months. Levels above 400 nanogram per ml triggers a visual field assessment. Visual field assessment is not routine during pregnancy. It is indicated for women who develop visual symptoms. It is also indicated in case of macroadenoma extending above the cella. It should be tested before pregnancy and every 3 months during pregnancy, even without visual symptoms. And finally, MRI is not routine. It is indicated for severe headache or visual field abnormalities. If the adenoma is enlarging during pregnancy, start management with dopamine agonist. Bromocriptine has a good safety profile. However, either bromocriptine or cabergoline can be used based on a patient past experience and tolerability, because both drugs have a good safety profile. Surgery in the second trimester is considered for persistent of severely compromised vision, despite several weeks of dopamine agonist. However, if surgery is required in the third trimester, it's better to be postponed after delivery. And finally, in the postpartum period, breastfeeding is allowed if the patient has a stable adenoma during pregnancy. In this condition, stop dopamine agonist and allow breastfeeding. On the other side, breastfeeding is contraindicated in women with visual field impairment, as they require dopamine agonist therapy. In the postpartum period, monitor serum prolactin. In non-breastfeeding women, measure it after 3 months, while in breastfeeding women, measure it after cessation of breastfeeding. It usually normalizes 6 to 12 weeks postpartum. Regarding adenoma outcome, most women experience a significant remission after birth. Thank you.